history, please. Acha, can you guys hear me?
Yes, we could hear, and they just presented the history here.
Yeah, and have you seen the angiogram?
We did. We saw the diagnostic films.
So what do you think?
Looks equally difficult, if not more, compared to last case.
No, it cannot be more difficult than last case. And it was such a wonderful demonstration, Samir, you know.
It was, yeah.
It was.
It was amazing.
Acha, here, in this case, let us take a couple of views with guide catheter. No, okay. Go to LAO cranial. What will be your strategy of wiring? Will you like to go ahead with a microcatheter or de novo wiring? Or with balloon?
I would use a microcatheter because of disease proximally, because it'll allow you to torque more refined control.
Okay, what is the opinion of the other panel friends? Get me run through extra floppy.
I think there's a channel there. I think you may try just bare wire one through.
Run through just
Bare wire.
yes, that's what I am. Tak, I am not as old as you, but I also behave as old as you.
Understand. When we see this case, oh my God. Every case is a young patient, 41, 51, with a bad EF. So I feel very, very lucky to sitting here.
Oh, but the last case had lot of lessons to learn. Yes.
Absolutely, absolutely. Learn from the
2
master.
millimeter na Riuri, 1.5 and 2 Riuri, and even guide plus 2 bhi pachi lai rakjo.
Yeah.
Tejas sir, this is Dr. Lakshman Das.
Yes.
What's the guide selection? How you justified the guide selection in this patient?
This is a regular JR case for me at least, yeah. Because the artery lie and everything is perfect for JR. What do you think, Avtandil?
Absolutely agree. The ordinary GR4 is quite appropriate in this situation. So, and what I see, I agree with Samir because microcatheter would be better in this situation because we have a diffusely disease RCA with high stenosis in distal portion, and good support we need in this case. So, and Tejas started with floppy wire, right?
Yeah, it is extra floppy run through. That area is very tough. The area where my wire is getting trapped.
Yeah,
Scout.
we could see that. Tejas, can you teach us what situation you can using the hydrophilic wire?
Hydrophilic, nowadays I am not using whisper much, only very rarely, because we are so used to this. Go to RAO, let me see. Yeah. No.
What about field FC or some kind of Sion?
Again, we are so used to this tactile feel of this wire. Go to LAO. Get me 1.5 by 15 Riuri. Inject. Get me 1.5 by 15 Riuri.
I think with balloon backup, you might get good pushability.
I hope.
Yep.
That's a designer collection, huh? The cases.
They are. Each one is difficult in its own way.
एक सेकंड यार नाखी दे Yes.
What is the size of this balloon?
1.5 15 Riuri Tarumo.
Excellent profile for crossing.
I think this is genuinely my favorite balloon for the most difficult case. In fact, I don't use anything else. Ah, oh no. Oh, torquer.
What's happening?
No, I had lot of resistance in the proximal lesion.
Oh, okay. Yeah, that disease proximally is very,
Very calcific type, I suppose.
very binding, yeah.
BP, yeah.
Guide is in the lesion.
Wait for some time. Allow it to perfuse. बराबर છે? Pressure बराबर છે. Now, inject and see. Here I will be going step by step rather than hurrying, because one, mistake can really make the difference of success and failure. And I mean, right? Hopefully, yeah.
Yep, you're through.
Yes. Samir, the last case, what Dr. Saito showed, I had discussion with Malcolm Bell here that he will finish it in half an hour, because these intra-arterial collaterals, yes, his track record over here has been so good. But see, the important lesson to learn is at his level also one can fail. The problem was in India, AL 0.75 is not available.
Right.
Yeah, and he badly needed that backup inject.
I think the engagement at the right and the proximal right disease is a very big negative risk factor for CTO of right. For antegrade approach.
So we simply start dilating. Aman, go ahead. 10, 11, 12, it is 1.5. Get me 2 by...
So in your case, Tejas.
Yes.
So you just put a small balloon for extra support and a wide goal.
See,
Is
what
it-
happens is...
Or you have any other trick?
Yeah, it will convert extra floppy wire into a sort of intermediate wire situation. That was my, whole intention. And see, you have seen the artery before. And if we get result, we will show you how big it is. This is an extremely negatively remodeled Indian artery.
Yeah, I agree with you now. So in what situation you're using microcatheter to support?
Yeah. I sometimes, most of the times I use this type of balloon. Sanjay uses microcatheter. He loves microcatheter. And it all depends on what tactile feel you are comfortable with. Difficult. Yeah.
What length is this balloon?
15.
15. And it has a mid marker?
Yeah, it is. This was the toughest area actually. See, you can see there is
20.
deflate. There was bubble. Again go.
Wait.
Okay. I think bubble, deflate.
You think it's...
Now,
Yeah.
this is what is my regular practice. I will try and see how smoothly it goes in and out. પેલી બાજુ લગાડ દેજો. આપણે પેલા South Indian patient.
So far it's behaving, huh?
Now it will be done now. This will be now 20 minutes next, and everything because this was the area where it could have taken some time. Okay. Let us check the result. Look at this, huh?
Yep.
So
You got the
now
blue channel.
I will take a 2 millimeter balloon and dilate again. Again Riuri, yes. Or else, yeah. Riuri, you have not opened, ne? Then give me NC emerge. Again 2 by 15.
Why not 2.5?
The lower artery does not look like 2.5. So Professor Akasaka, Oh, sorry. I think we literally, squeezed you during this 1.5 day. And let me ask you, in Japan, is this case in this case, uh, will you like to do IVAS or after stenting?
Yeah, it
Okay.
depends on the institution, right?
No, normally pre-stenting.
Still lots of calcium, so
That's what
yeah, I like to
do
use
IVAS or OCT.
OCT, but
OCT again, these artery may or may not give a very clean picture. Are up to you. You tell me what you want.
right. But yes, I think we can identify the calcium much better than the IVAS, but most of the Japanese physicians like to use an IVAS.
Okay.
Or only our institution or some institution like to use an OCT.
But let us show, the audience here how the IVAS image looks in this diffusely diseased artery. Just prepare the IVAS.
TJs, you said that the OCT cannot give a good imaging in this case. Can you
Sometimes
explain why?
very diffuse disease, the catheter does not behave, when you inject and the things come out.
Gets
Go on
stuck in
6.
the calcium.
Yeah,
Time
it
of
gets
pullback.
stuck, and you get lot of whirling type of thing. 6, 8.
8.
I think the length is very long, so not only one pullback is not enough
Yeah.
to get a full image by OCT.
Yes.
But compared with an OCT, IVAS can get a full image
Yeah.
from the distal to the proximal.
And here, if at all we are doing OCT, we have to take at least 2 survey images, 74 millimeter length. Still, there may be 3, not 2.
So this is going to be a full metal jacket after the procedure, right?
Yes. But let me tell you, Lakshman Das, that we have seen time and again, and we are in the habit of doing check angios in this type of cases. It works out extremely well in most of the cases. And it reminds me of my balloon angioplasty days till 94, 95 in this country, 96 in this country. We were doing this, segmental balloon dilatation and leave the patient on TIMI grade 2.5, TIMI grade 3 flow, and we used to call them for the check angiograms after a month, 2 or 3, and then after 1 year. And most of the patients had, except for some at that time, because the stents were not there, sort of irregular lumen, but good lumen.
What will be the antiplatelet strategy for these kind of patients who have got a full
minimum
metal jacket?
minimum 1 year of aspirin Brilinta if the patient tolerates. If doesn't, and if there is no contraindication, then prasugrel aspirin, and then you can switch over. There is no problem. Look at this. The artery has started looking bigger. Now we will see with IVAS. Out. पंचर करा ही देजो सामने पंचर ही करा ही दो फिर आ गया.
So what do you predict with IVAS? There will be a lot of 360 calcium or nodules or scattered less than 180 calcium?
It is a practically negatively remodeled artery, multiple level healed plaques, calcium fibrosis, but the least of the fat. Professor Akasaka, what is your contemplation?
Yes, the distal artery diameter is huge. Therefore, originally the proximal is very huge, and also the RV branch is very big. So maybe more than 3.5 or yes, around nearly 4.
Give me IVAS. Preparing.
Very complex region with lots of calcium, spotty calcium and nodular calcium, and as Dr. Patel said, healed plaque. Very complex region in this case.
Avtandil, I have a question. How frequently
you see this type of diffuse disease in Russia. in almost all cases.
And
Because
what is your
RCA
strategy?
RCA vast majority of cases diffusely disease.
Yeah.
And the challenge is how we can stent at this, because the mid segment seems to be relatively healthy, right? Without any stenosis, right? And I don't know, is it worth to stent it and make it a full metal jacket, or
Yeah.
maybe choose the landing zone by IVUS? So
It's a huge artery which has been narrowed because of the extreme distal, negative remodeling. And my experience is I like to jacket it, and 99% of the time, most of the branches are extremely well preserved. Let us see.
And what will be the stent of choice? Like, will it be a Nagomi or which is available in a long lens now, about 50 millimeters lens?
I think
Probably with a large open cell side branch.
Nagomi, Nagomi we have recently got on our shelf. Here, I think I will use the stand
Onyx?
which has sort of even if there is a medium sort of radial strength, it is all right, and it should be practically, bioabsorbable polymer. And I have planned to use cruise here, because the balloon went in smoothly, the stand may give you problem, and whenever there is trackability issue for a long stand in a heavily calcified fibrotic segment, my preference is either onyx or cruise. And in extremely difficult situation, because ultimately it's all about the success on table first, and then you see whatever. In cruise we have seen that the long-term results they are able to maintain if you are giving a good result at that point of time.
Cruise is from which company?
It is an Indian product, and that is the
Okay.
only Indian stand which I have on my shelf.
Okay.
Okay? एक मिनट लाया अगर Okay, fine. Let us start.
Yeah.
Pull back started. Yes.
This is the distal portion nearly normal, right?
Can we see the IVUS screen?
Yes. Yeah. We have the one branch.
We see it.
And flush. No image. Flush. The customer.
Flush.
Yeah. Right. Come back to the image. Very eccentric plaque, right? From 3 to 9 o'clock. We can identify the lots of plaque.
There's negative remodeling.
Yeah, tremendous
here is a
negative
negative
remodeling.
Yeah.
Yes.
Again, negative remodeling.
Yes,
Yeah.
that's right.
It's very dangerous.
Yes, and here is in the normal size, right?
Yep.
Yeah, and the calcium, right, around nearly 108 degree, and here also the nearly normal, only fibrous plaque, right?
Yes.
Yes. So there are lots of spotty, plaque.
Yeah,
Here also the
fibrosis.
eccentric fibrous plant. We have the branch, might be here, RV branch, right?
This Thandil, this is the normal segment
Yes,
you thought,
yes.
but see a lot of fibrosis. Yeah.
Right. Yeah, and also the branch, and yeah, at the site of plaque, there are lots of positive remodeling, but without plaque, the negative
Yeah.
remodeling.
Can you
right.
tell me, Professor, the diameter?
Diameter in,
Distal, proximal, and mid part.
okay, I'll try. Yeah, right.
No, is there a point in preparing the bed further with some scoring balloon so that this fibrosis can be modified and bring in a better stent? Probably it may grow with a nitro subsequently.
The problem here is this is the time when at least I will like to hold my nose using those type of cuts in this extremely negatively remodeled RCA. Instead, I will deploy the stents, and then if need be, I like to expand them properly.
Okay.
Yeah, just to avoid some sort of perforations and other things.
Yeah.
Because there are quite a few patchy areas of differential calcium and fibrosis. And these are the areas where, we don't know exactly how the cutting balloon is going to behave. At least we have some idea about the non-compliant balloon, how they behave in this situation.
Tejas, will you like to wire the PD, which seems to be narrow at its beginning, and also flow is little bit less? Because
Yeah.
that additional wire will help you to
Now,
advance your catheter.
it's a good question. Huh?
That is column effect
There are
from the
multiple
LED
PDAs are
collateral.
there. I don't think that is not going to make any difference.
At least I tell you, because it is 99.9%. Do you agree? At this origin. It means it is extremely, ischemically preconditioned artery. So why should I care and create lot of sort of crowding inside? This is my view. Yeah.
I do agree with that.
The distal RCA has good collaterals from LED.
Yeah, that's the point. My 2.5.
So, Dr. Akasaka, how do you pick the landing zone in this very diffusely diseased vessel?
Very difficult.
I'm watching your movement of the cursor. And
See, very happy to hear this statement from you, because we all the time find it difficult. But if you say difficult, means it is genuinely difficult.
The proximal site, near
I think just before that second PDA or so, that is maybe a fairly safe landing zone.
Get me guide +2. And please quietly watch what I am doing. You may not like, you may like, but this is what in this, because I know that if I use a 48 millimeter stent at this point of time, it is going to get stuck somewhere in the middle. And then pulling back, if I can create some problem.
Yeah, it's a good idea to bring in Guide Plus because it can walk through without any support on the wire, and then definitely it will safeguard the stent, and definitely it will facilitate the good. And with this guide, that support of the Guide Plus will be extremely useful, and you can deliver very easily.
For all those who don't know about this product, it's a Japanese product from Nipro. And it is a guide extension catheter, and I have become, a big time fan of this guide extension, because I want to show you how. Yeah, just remove it, Aman. I like to show the property in vitro. See, can you see the tip?
Can we go for the bigger picture?
Yeah, can we expand
Can you see the
this?
tip?
Yes,
See?
now we can. Yeah.
You see, it's so soft. It is extreme, and it moves like a snake. Chalo, go ahead.
So it's 2.5 distal, 3.0 in the mid, and the proximal edge is 3.5. Is that correct, size-wise?
Yes, we are now trying to measure
It
from
is-
the proximal to the distal now. Okay, I will show you later. Wait a moment. Here is in the mid portion. Can you see the IVAS?
Yes, we could. Yeah.
Okay. Right. This is the mid portion, right? And then a little bit distal, right? We try to measure the negatively. Here is the negatively modeling area, right?
Sorry. Wire. Oh, my wire came out. Just inject.
That's why they want to protect. That's a branch.
No problem. Okay.
Okay. Can I have a comment?
No, IVAS didn't show much of the dissection planes or and very ugly flaps or nothing. So I thought it would be safe to push back the wire.
See, that's the reason why I am using guide +2. If I had seen lot of dissection there in that region, I would not have used it.
Now, going back to sizing, would you size to the negatively remodeled area?
Yes.
You watch this Guide Plus, how it goes. It will smoothly go in.
Wait.
it doesn't need even a balloon support actually. If you have, it is good, but it will walk in usually.
Get me 2.5 by 48 cruise. Bas, that's it. Keep it there. Let me pull it back. 2.5 by 48. Quick.
Where
Quick.
is the guide?
Pressure.
Only problem is the lumen is very compromised. This may also compromise the flow distally. But
Yeah.
it is a preconditioned, so it may be all right. And sometimes,
Quick.
sometimes you will see the dampening of the pressures on the
Yeah,
screen.
I see it all the time here. That's why.
It will increase your blood pressure and heart rate.
Yeah, please go ahead. Quick.
This one, it is 4, 2.2.
चल जल्दी कर. एक नानो इंजेक्शन गोविला हमना नहीं. चल या.
Okay.
I have to go till that area. Yeah. Hold up.
Nipro
I would have
card.
prepared that with angio scalp or something like that.
Okay,
2
Nipro out.
millimeter, 2.25.
I am there.
Nipro card.
Wait.
Yes, get rid
Yeah,
of
it has
Nipro.
gone. It's,
Okay.
Yes,
I think this cruise is
yes.
some more flexible.
Wait.
and,
Let the blood pressure come up. Yeah, it
Get
has
it
come.
perfused for some time.
Yeah, the dye, can we see the screen? Yeah, the dye disappeared, so that means that the flow is good.
If we would have waited for another 1 minute, we could have seen ventricular fibrillation on the screen. I know that. Okay, inject. This looks good. Go. First stent here. Wait.
Can we pull back a little bit?
Yes.
I
And then
thought
we
this
come
is
back.
too
Yeah,
far
yeah.
away.
Yes, this is the place. Okay, go.
This is fine.
This is fine. 10, 12. Keep it on 12 for some time. Keep it on 12 for some time.
Looks a little big.
Yeah, it is at, yeah. Now come down. Wait. A millimeter back, I will come. Just a millimeter back. Wait. Let it deflate. Yeah. Go on.
Senior.
Now go on 18. 18. No problem. Aman, no problem. Go.
Yeah.
18.
18.
Deflate. Okay, we will dilate with the same 2.5 balloon, the segment, whatever, visualization we can get, and then knowing the length of the another stent. Okay, inject and see first.
What are the lengths available in this cruise?
Up to 48. 44, 48, then 40, and then,
There's no diagram.
yeah.
There's a middle.
Go up here.
You
15.
dilate. Yeah.
And what is my problem? You know now. This going with a bigger stent and overlapping is going to be a major issue. So I will not be overconfident about, removing the guide plus catheter here at this point. Go up here, 15, 18. Deflate.
40.
So, Professor, in the middle, 3 millimeter.
Yes.
Good.
Yeah, I try to explain, right? Yeah, this is the distal portion, right? Can you see the IBUS?
Yes, we could.
Yeah. This is the distal portion. The vessel area is around 3, right? Mm-hmm. Yeah, and this is a negative remodeling portion. Vessel area is around 3, right?
Yep.
And then a little bit, this is a mid portion. Lumen area is around 3 and vessel area is 3.5. And a little bit proximal, the similar, right? Lumen area is 3 and the vessel area is nearly around 4. And this is just proximal portion right?
4.2,
Area
yeah.
of the lumen is 3.5 and vessel area is
Senior?
more than 4.
Right.
Right.
Hey,
It
what is
already
that?
grown.
Distal?
Yeah.
Perforation?
Distal is perf.
No.
Yeah, small perforation.
yeah.
No, it was there before.
It was there before.
Yes. It is the
Huh?
collateral, beginning of the collateral.
Let us see AP cranial view. Wait. We cannot ignore it. Nothing can be ignored. Yeah.
No. it's
No.
not.
No. Looks good, nah, Samir?
It looks very good so far.
Yeah,
Prob-
the-
this
Wait.
angle.
Keep that view. Let me put it in the lower branch, the wire.
Yeah, and I think, it might be good to review the old angiogram anyway, just to confirm.
Okay.
Yeah.
Yes. Go to LAO. Show the old angiogram.
The first shot you took in the LAO,
We can see it after the balloon dilatation. The one
Yeah.
after the balloon dilatation.
one of those. Oh yeah, after the opening up, you're right. Once you establish flow. Somewhere there, yeah.
No. These are all fluoro save.
Right, balloon
Yeah.
dilatation shots. And now,
So that
Yes,
dark-
yes.
dark-
it
dark
was there.
Yes, it was there.
Collateral.
It's just that wire buckling into that.
So,
joint.
Professor, which 3 by 48?
Yes.
Get me 3 by 48, Cruz.
The cranial picture shows how big it is distally.
Yeah.
It has a lot of myocardium that it feeds.
Sometimes we have the problem, this guide plus, after the usage of the 3 or 3.5 balloons, when we try
just
to pull
remove the
them
dye.
back,
Stand
they
deeper,
may
the
not
dye
come
there.
through the tip. Then we may be forced to remove the whole set, guide plus along with
Let
the
it
balloon.
be flowing well. Pressure.
So that happened a couple of times.
Yeah, it's also dependent, at least in our lab, on the stent type.
Dye remove करो
The synergy seems to stick more,
because
the stent balloon,
it goes.
compared to other two.
Somehow, the Indian arteries don't behave like the regular coronary arteries described in the literature. Somehow.
I think they're very inflamed.
Inflamed, yeah, that's the point.
I think the high prevalence of the diabetes is crucial in this, and that's why I always prefer, even though 6 months dual antiplatelet, I prefer to keep them for a year's time.
Excellent.
And then only for reasons I withdraw.
That is
one of
what
them.
I also do. If the patient has no other issues, aspirin, clopidogrel 75, I keep them for some longer time or maybe indefinite time. If I come across, because our thrombogenic profile is a bit different. Yeah. Wait.
I think when we see effective anti-inflammatory pharmacotherapy,
See
it'll help.
now hope for the best. I am
Yeah.
going without guide plus. Oh, lovely. It went in just like that.
Yeah, that's a good stent. Very
Yeah.
good. Yeah, very
Just
good
so.
trackability.
Go up here. Come on, Aman. 15.
6, 8, 10,
Look at the size of the arteries.
12, 14.
Yeah, it doesn't look
15.
as very big. It's not very concerningly big.
Deflate.
Looks nice.
Yeah, proximally it is taking time to get
Wait.
bigger. Probably we
Let
have
it
to wait.
deflate. Let it deflate. Let it deflate.
Guide plus out.
Karusu. Aju,
Need
Mare-
one more
No,
stent.
Wait, yeah. Wait. See, its stent is not going in. I want it to go.
Correct.
So what I do is, Aman, inflate at 3 atmosphere here.
So you want to dilate the overlapping
Yeah,
area of
yeah.
the same balloon?
No, but not with the high pressure, yeah.
What's the balloon here? Because
Semi-compliant,
It's a
deflate.
semi-compliant, okay.
Semi-compliant. If I can't dilate, I am not going to waste my time here, for sure.
Yeah.
I think it's also very long. It did go a little forward, looks like.
Take it out. Now the third one, a shorter one.
So you want to cover the
Hey,
oh,
wire has come out.
wire.
Hey, no problem. We'll go in again. Let us remove this crowding. Just remove the crowding.
So now your guide plus will be out.
Yeah, everything out. Yeah.
Yeah.
So हमें पंचर कर दी तुझे?
Guide plus out.
Now you are planning to cover the ostium or you are
No. I will leave the ostium alone, but yeah, I will put another stent in the proximal area just to make sure that, you know, here I will like, otherwise I am minimalistic, but somehow I love to treat this diffuse disease this way.
Why?
Yeah, wire. This is the best loop for traversing through the stent.
correct.
Okay, just inject and see.
Wait.
But you should be careful how we entered the proximal portion of the
Yeah,
stent.
that's right.
So you have to be careful.
Okay.
It may be even a good strategy
Go
to
to
try
epicranial.
Oxford balloon
Let me put the
to
wire in.
or dilated balloon to go through that.
Samir, can you see and talk? Can you see how big is the artery now?
Yes,
Scout.
it grew up quite a bit. It's really encouraging to see that it's large.
Oh no. Oh. I think here I will not take a chance, and I will like to, because I am supposed to do IVUS afterwards. Let me stand and get me another run through wire. Get me the stand. LA ho jao. LA. Inject.
Yeah, the tip
Length.
of this wire is not behaving.
Yeah, and then you are creating perforation. Professor, what is the proximal? Wait.
Yeah,
Wait.
proximal
Now
site-
scout.
Yeah,
Yeah,
proximal is
3.5.
yeah more than
It is 4 on
3.5.
IVUS. We can use 3.5.
More than 3.5. The vessel area is around 4, right?
4. But we can take 3.75
Yes.
by 18, 15, 18. Cruise.
Yeah, lumen area is 3.75, right? Yes. So it's okay. And the diseased portion is positively modeling, right? So it might be okay.
This is actually, we are going to see the ideal result for OCT or IVUS in this case, because the struts will be deeply buried into media, for sure.
What about the relationship of this marker and this stent in this cruise? Is it like R0 and alpine, or it is different?
Yeah. I mean, there is some balloon outside. I don't remember, I don't know exactly, but yeah, there is some portion projecting outside.
It's 0.5 millimeter.
4.
0.5 millimeter.
Or another is 3.5? Yeah, we can have 3.5. By, hey, which one? 18. આ કયું છે? હા?
375.
375 is not available. It's okay, no problem. 4 નો લઈ લો, low pressure. 4 નો બી લાવો, 4 by 18. કયો છે? 16 ને 20 છે ને? 16 should be fine, professor. What do you think?
Yeah, I think should be all right. Yes.
So 16 નો 4 નો લાવો, 4 by 16.
Oh. So you will deploy at a lower pressures, or how the status?
Yeah, I think around 12 atmosphere.
That is a nominal 12.
Yeah. $16, yes.
The wire has come back.
No problem. We can stand proximally.
Yeah.
I will use another wire, rather than creating a mess here. Inject over. Let me see. Yeah, inject.
They're not seeing. Okay,
Yeah.
fine.
It's okay.
There's enough overlap actually.
Yeah. Let
LO
us.
corner.
Yeah. Wait. No. Wait. Chal scout jo do. Yeah. Now let me check it out.
Back,
Okay.
Back.
You have to
Back.
come back a little bit.
Yeah. Little back.
Little
No,
in.
no, too much. Yeah.
I
Right.
think, okay, go
This
up.
looks. Wait.
It's fine.
Take a shot and then
Go up.
Yeah,
Go.
it's okay.
This is
okay.
perfect. 10, 12,
Great.
12, 12. Keep it there. Deflate now.
Kadina, we need to go with a new wire.
Yeah. Another new wire, please. And then we will do IVUS. The patient blood pressure and everything well maintained. Inject. Are we in? Scout. No. Scout. Okay. Inject. Look at the size of the artery. Any comment?
Yeah, it has
Looks
grown
good.
well actually.
Looks very good.
And none of the branch has been sacrificed, including that critical lesion branch.
The critical lesion actually looks a little less critical.
Yes, because of probably the plaque shift. Professor, you are telling sometimes that side branch looks better,
Yes.
after stenting.
Yeah, great.
Yeah. Yeah, perfect. Yeah, you. Now, just see how Aman gives the curve when I want to enter in. A sharp U-turn. Very good. So, go ahead. Because you don't enter the proximal malapposition if at all. There's no chance here, but still. Whenever I am working in, wiring the stented area, this is the way.
Oh. Yes. The guide is coming out. Okay. Yeah. Just push.
You saw this?
Yeah.
Go to
That was
eleocranial.
It definitely did not wire a strut.
Yeah. Scout. If at all I can enter that side bigger branch, I'll be very happy. Otherwise, it's okay. This is fine. Inject and see, and then we. Okay, this is okay. Now get me the IVUS. See, it looks a brand new artery, huh?
Yeah, the diameter definitely is very
Show the first
encouraging.
diagnostic angio, Parag. The next view, it means. Look at this. This
Yes.
was the size.
Yep. Do you
Okay.
think on the latest picture we took, in the mid portion there is a little bit of under expansion
Batao, go back.
compared to distal?
Yes.
Yeah, but that's an angle there, Samir. That's an angle. I don't know. Well, let us check it by.
Yeah, I was pretty sure, but I think that's where your MSA is going to be.
Yeah.
Yeah. Yeah. Until bifurcation, RCA the size is very similar, right? So
Yes, it should be like a tube, right?
yeah.
It should be uniform,
Yeah, right.
no tapering.
That's right.
Okay.
Enough.
Although, Dr. Akasaka, I have to say,
Huh?
yep,
Everything is covered.
in reality, it's not always the case.
Distal.
Right.
Okay. Chalo, let's see now. Huh?
A little bit distal.
Avi, I cannot go further. Huh?
Yeah, okay.
Yeah,
okay.
yeah, go ahead.
Here is in the distal branch, right?
Yes.
Yeah, start. Yes.
A stent.
Yeah, stent is just on the side, small branch.
Beautiful.
Right? Yeah, and the position is very good. The size is about 2.5 or right, 2.75. Attached very well. It's a very normal portion in the distal side. And another branch coming, and you can identify some plaque. Yeah. And here is around 2.5, right? Yeah. Or a little bit under expansion at the very thick plaque.
Yes.
Yes.
Right there is MSA there
Yeah.
probably.
Around, yeah, we will measure later, right? But generally speaking, 2.5 in diameter, right?
Right there. Yeah.
Yeah. And here is an eccentric plaque, and
Then it gets
from
bigger.
here the bigger, right? And 3 we can identify in diameter, right? Very big positive remodeling in this portion, right?
Right there. Yep.
Yep.
Calcium.
Yeah, calcium, right? And here also the yes, around 3 millimeter in diameter, right?
Yeah. It doesn't look bad in that area.
Yes, yes.
Doesn't
Yeah.
look, that was the one I was worried about, and it looks
Yeah,
pretty
yeah.
good.
That is deceiving because of the angle,
Angle.
there.
Yeah.
Yes.
You're right. Absolutely.
Here is in the branch, and also the positive. Around here we can identify the negative remodeling, but this portion is okay, right? And here also we have the plaque and positive
would bookmark
remodeling.
that,
Yeah. The size is nearly 3, right?
Yeah.
Yeah, it's good. And
Right there
yeah,
is. Yeah.
it's small.
That's the little MSA
yeah,
there.
yeah.
Done.
Yeah.
So, what do you think, guys?
I think we measure and see if we got our endpoint, but overall looks good.
Yeah, so we will be switching over. I'll take another couple of views and then we switching over to the last live demonstration case of the day. Again, it's not very easy, so we can continue till 1:15, no problem. Then you can have good lunch, no problem. So, are you guys tired? If you guys are not tired, I have the case ready and Sanjay is there already. We will work on it, yeah.
What does the audience think? Go for the case? Raise your hand if you do. Okay. Well, 100% approval. So we should be-
100%, good.
Yes.
Epicranial.
Yep.
But see, this is what was my contemplation, before. I could visualize this artery. For sure, every branch is perfect and it is super dominant right, which looked like, a very small calibered and bad right. Thank you. I'm just switching over there
Awesome
within a
case.
minute. Yeah, thank you.
Very nice. Awesome performance. Thank you. Great.